Welcome to the Skinny Vodcast. I'm Amy Pfeiffer.
And I'm Nassim Miller.
It has been a busy month, Nassim. We covered the American Academy of Dermatology summer meeting in New York, where we learned about new approaches for treating aging hands.
Also at AAD, our reporters caught up with an expert on bugs who warns that feisty fire ants are making their way north.
And we're going to talk about new study results that may have found a neurological explanation for why some people can't stop using tanning beds.
So let's begin with hand fillers. Dr. Deanna Glaser talked with us about how to bring up loss of hand volume with patients. And she also discussed the latest advances in treatments for aging hands.
So this is something that's kind of a little unusual, I think. Not a lot of dermatologists are doing this. So can you tell us a little bit about it, how you select your patients and what you use to fill the hands?
So we've used fillers for hands for years, except that usually we've used fat. And as the hand ages, it starts to become very sunken in, and patients complain about the prominence of their veins, the prominence of the tendons, how the hands look old, and they really do age us. And so now what we're doing is, instead of using fat, which is perfectly acceptable and it can still be used, but now we're using more of the prepared fillers, hyaluronic acids, the calcium hydroxyapatite. You can even use poly-L-lactic acid. So basically any of the fillers that are out there we can use to help support up the skin, fill in those kind of deep sunken in spaces between the tendons and make them look more rejuvenated. And then on top of that, we might do some lasers to help take care of the brown spots, the liver spots, to really give a total rejuvenation package for the hand.
Would you ever use a permanent filler in the hands?
You know, for the most part, we're not using permanent fillers, just because if there is a complication, you know, it is a long-term complication. And the other reason is that the fillers in the hands, and these are all off-label uses, so these are not FDA-approved uses, but they last a long time in the hand compared to, say, the face or some of the more mobile areas. So even the hyaluronic acids, I can get a year duration for my patients when I use them in the hands. It's a very quick procedure to do. It's done in the office. The downtime is relatively short. Patients can start using their hands the next day, and we're getting probably about a year to even sometimes up to a year and a half duration with one treatment. So it's a really satisfying treatment for patients.
Have you ever noticed any side effects from this treatment in the hands?
So when you use a filler, the side effects are the same as any other usage of the filler. You can get some bruising, you can get some swelling, some lumpiness. You have to be careful not to overcorrect the hands and overcorrect with the filler, especially in the hands, because it does last so long. You can get some asymmetry where maybe you put a little more in one hand or the other, or one hand needed less than the other. And then I would say maybe the most unique adverse event in the hands is that the swelling can persist longer than just a couple of days. There are a few patients that the swelling will be mild but persistent for even a couple of months, and that's very frustrating for them.
How much filler are you putting into the hands?
Right, so that's a great question, because really for the hands, I think you don't need that much. I would say, depending on which filler we're using, like if we're using a hyaluronic acid, maybe 1 to 2 syringes or 3 syringes total for both hands. Maybe for something like the calcium hydroxyapatite, maybe 2 syringes total. And it gives you a really nice result.
If you've ever been bitten by a fire ant, you know how annoying and painful the bite can be. But if you live in the north, you've probably never seen a fire ant bite. But that may soon be changing. Our reporter Michelle Sullivan interviewed Dr. Ronald Rapini on the fire ants' northward march.
Hi, this is Michelle Sullivan, and I'm talking to Dr. Ronald Rapini about what's bugging you. And today, what's bugging him is fire ants, and they're on the move from southern United States up to almost into Virginia and up the East Coast into the northwest part of the country. Dr. Rapini, tell us all about these little guys.
Well, fire ants, they're ants, but they're a special kind of ant. If you want to look at one, get up close to one, they have an extra segment between their abdomen and their thorax compared to other ants. They have that little stalk that connects the abdomen to the thorax is a little bit longer with an extra segment there, so that's one way you can identify them. But most people don't like to get that close to them. But fire ants, the scientific name is Solenopsis invicta. It sounds pretty ominous, invicta, because they can inflict a pretty nasty sting. But some of the dermatopathologists like to call it a fire ant assault rather than a bite. or a sting because they actually bite and sting at the same time. So the dermatologists that are picky-unish about how terminology, they say it's a fire ant assault. But they bite you with the jaws, and then they pivot and they sting you with the rear end. So they're doing both at the same time.
Oh my gosh! So when you see, do you see patients in your office who come in with just a plethora of assault
Yes,
scars?
we see some patients who don't really know what it is, and they come in and they say, "What is this painful spot that I got?" And usually they're pustular; they have pus in. Fire ant bites are a little different than some of the other stings and bites in that they become more pustular than most of the others, and they're more common on the lower legs, where you think they would crawl up your leg. But you can get them other places, of course, too, wherever they get on you.
So for treatment for someone who's not completely covered with fire ant bites and has a super infection, what do you recommend? Is it a prescription strength corticosteroid?
Well, usually they're self-limited. The pustules will go away, but people get miserable from the pain of the sting. We give people topical cortisone. You can buy the over-the-counter 1% hydrocortisone, but that's a pretty mild one. There are prescription strength cortisones that are way stronger. Sometimes we use antihistamines orally, and if somebody's really bad, we can give them oral cortisone. But the truth is it runs its course and goes away most of the time.
So your northern colleagues might not recognize what they're seeing if they have someone come in with fire ant bites.
Right. I mean, they don't look like some of the other insect bites because they're more pustular, and they don't, they may not itch as much. They may be painful. So, the patient might even get a skin biopsy because they might not know what it is.
And how far north are they ranging now?
Well, there's that map from the CDC, and they're getting up into Washington and Oregon State and up into Virginia and some states that are a little further north. And the usual Texas-Florida corridor there is the most common area where they're found.
All right, let's switch to the tanning bed study. Amy, one of the dermatologists I interviewed at the AAD summer meeting actually called them tanning coffins. And the profession as a whole is trying to discourage indoor tanning and inform patients about the dangers. There is now new research that shows that there could be an addictive neurological reward and reinforcement system in people who tan frequently. I had a phone interview with the study's author, Dr. Brian Adanoff. So let's take a listen.
What we did, we had these 7 subjects come in, and they didn't know which time they were getting the real UV and which time they were getting the fake UV. So one time they came in, they were under, they got the real UVR. The other time it was filtered out. And as soon as they went under the light, they were injected with a radioligand that measures blood flow in the brain. And it captures what's going on in the brain over a period of 1 to 3 minutes. So it was during that initial time under the tanning light that we were able to look at, and then the scan is done later on. But the isotope kind of sticks around in the brain, so we're able to get a picture of what happened during that time. Subjectively, we asked them before they went in the tanning bed how much they felt like tanning, and then immediately after the session, we asked them as well. And what we found from a subjective point of view is that when they went under the real light, their desire to tan dramatically decreased during the session. If they went under the fake light, their desire to tan did not change. Looking at the blood flow, the regional and cerebral blood flow, we found that when we compared the real light to the sham light, we saw that there was increased activation in some areas of the brain that are highly related to reward and or craving. The most notable of which was the dorsal striatum, which is the striatum is a part of the brain very involved in the experience of reward. There's a whole field of study, psychodermatology, where there's connections that I think dermatologists and psychiatrists in practice see all the time between the skin and the brain, but we really don't have any good explanations as to what those connections are in terms of something like UVR having an effect on the brain. So that's of interest. From a practice of dealing with people with skin cancer, who tan a lot, our present modality is probably to tell them that this is bad for you, you should stop. Much like we did to cocaine addicts in the 80s, when before medicine came to the realization that cocaine really is addictive, even though there's not a visible withdrawal syndrome. So people would come in, they'd say, I can't stop using cocaine, and they'd be told that it was not addictive. In the same way, if we, the study is still a long ways from that, but if we can see brain changes due to UVR, that these brain regions are involved in reward, the next step would be to think, well, if it's rewarding, then maybe it has the potential to become addictive. And if it's addictive, then we really need to approach these people differently than we presently do.
That's an interesting study. Let's move on to our monthly feature, Cosmetic Counter, with Dr. Lily Talakub. This month she talks about cleansers and helping overwhelmed patients find the right one for their skin.
When our patients come in and they complain about eczema, dry skin, itchy skin, irritated skin, the first question to ask the patient is, what cleanser are you actually using? People that have hand eczema, that really have dry, irritated, rough, cracked hands, oftentimes are washing their hands with antibacterial soaps. They're washing their hands multiple times a day and not replenishing the moisturization with a moisturizer after washing. So the first question to ask these patients are what cleanser they're using, whether or not it's an antibacterial cleanser, whether or not the cleanser is too harsh for their skin, and oftentimes just replacing the cleanser with a mild, non-irritating, non-lathering cleanser will prevent this dry skin. Using a moisturizer may not be the answer. If you decrease the amount of cleansing or scrubbing or detergents that are applied to the skin, oftentimes dry skin improves on its own without the need of an excess moisturizer.
That's it for us this month. Make sure to visit skinandallergynews.com for daily dermatology news. And don't forget about our free iPhone app. Search for Skin and Allergy News in the App Store.
Thanks for watching and see you next month.